Treatment choices. Local versus Treatment choices. Local versus systemic treatment. Prostatectomy versus other treatments. Watchful waiting versus treatment. Early versus delayed hormone treatment. Maximal androgen blockade. Intermittent androgen blockade. Treatment for elevated PSA. If the cancer is localized to the prostate gland only, stages A, B, C, the first treatment should be aimed at the prostate gland only. Hormonal treatment should be held in reserve for possible use later. If the cancer has spread outside the prostate gland, stage D, treatment aimed only at the prostate will not succeed, and there is no point in removing the prostate if the cancer has already spread. Prostatectomy versus other treatments. Radical prostatectomy has the best known 15-year cure rate. If the patient has a clear 15-year life expectancy, then radical prostatectomy probably should be undertaken after all the potential risks have been considered. In general, prostatectomy is best for healthy men under age 70. However, other forms of treatment have excellent 10-year survival rates and should be used for less healthy men under age 70. And watchful waiting versus treatment. Many individuals can elect conservative observation or no treatment for their cancers. Many prostate cancers are slow-growing and may not kill the patient. The younger and healthier the patient, however, the less often watchful waiting should be used. For patients over 80, watchful waiting should almost always be considered. The risk in watchful waiting is waiting just a little too long until the cancer has spread. The best cancers for watchful waiting are early cancers, stage A or B, with low Gleason scores, Gleason score 3 or 4. Early versus delayed hormonal treatment. In patients with stage D cancer, some early studies have suggested that delaying the onset of treatment until the cancer causes symptoms such as pain or urinary difficulties may not shorten the patient's lifespan. Because of this, some physicians recommend withholding treatments until symptoms occur. However, more recent information suggests that early treatment may be more effective. Maximal androgen blockade. In patients with stage D cancer, some studies have shown that maximal androgen blockade results in longer survival than with surgical or medical castration alone. Maximal androgen blockade combines LHRH analog, or orchiectomy, and anti-androgens. Some physicians consider the benefits of maximal androgen blockade to be relatively modest, and this is weighed against the cost of treatment with maximal androgen blockade. Intermittent hormonal treatment. This refers to any form of hormonal treatment that is given short-term, usually a few months, until the cancer is considered to be in maximal remission. At this point, the treatment is withheld. Restoration of treatment takes place when the cancer becomes active again. Treatment for elevated PSA. All hormonal treatments are effective in normalizing PSA, especially if this is the only manifestation of prostate cancer. The commonly affected situation is a rising PSA level in the blood of patients with localized prostate cancer treated by prostatectomy or radiation therapy. The long-term benefits from hormonal treatment in this setting has not been established. The 5-year relative survival rate for men with early-stage prostate cancer is 92%. The 5-year survival rate for men with advanced prostate cancer is less than 20%. Therefore, screening tests for cancer are done to detect cancer in its earliest stage when treatment is likely to cure the disease. These tests are usually carried out on individuals who are at most risk for developing cancer. In the case of prostate cancer, these are men over the age of 50, men with a family history of prostate cancer, and African American men. It is not yet known how effective screening for prostate cancer will be in reducing cancer deaths from prostate cancer. A study is now being done to determine this. The digital rectal examination, prostate-specific antigen levels, and transrectal ultrasound are all tests that have been used for screening. Studies have shown that digital rectal examination can detect a cancer 55 to 70% of the time. This test may be done easily as part of a routine physical checkup. Transrectal ultrasound, TRUS, can detect twice as many early cancers as digital rectal examination, and the majority of cancers detected are considered curable. However, transrectal ultrasound is expensive as a screening tool. Therefore, transrectal ultrasound testing of the prostate gland is not usually used alone as a screening test for prostate cancer. More often, it is to be used if a digital rectal examination or a PSA test is abnormal. Prostatic-specific antigen, PSA, is also used along with the digital rectal examination as a screening test for prostate cancer. The PSA test can help to detect cancers when they are small and may be cured by local treatments such as surgery or radiation therapy. However, it may also find some types of prostate cancer that never grow to cause a problem in a man's lifetime. These types of cancer are sometimes called latent prostate cancers. In some cases, it is difficult to determine which cancer should be treated immediately with surgery or radiation, and which tumors do not need to be treated right away, if at all. The PSA test has a 75% chance of detecting prostate cancer when it is present. PSA level can also be elevated when a prostate gland is enlarged due to benign prostatic hyperplasia, BPH, and no cancer is present. Therefore, an elevated PSA level does not always mean that a man has cancer. Additional PSA blood tests, transrectal ultrasound, or a biopsy of the prostate gland must be done to determine the cause of the abnormal test. One should discuss with his doctor whether or not he should have a screening test for prostate cancer. At present, there is no scientific proof that screening for prostate cancer in men without any complaints reduces the risk of dying from the cancer. A research study is underway to evaluate the benefits of screening procedures. However, it will take at least 16 years to complete the study. In the meantime, the American Cancer Society and the American Urological Association have recommended yearly PSA levels and digital rectal examinations to men over 50 years of age. Diet. It has been estimated that 35% of all cancers could be caused by dietary factors. Diets that are high in fat content, in particular fat from animal sources, have been linked to an increased risk of developing prostate cancer. Studies have found that increased consumption of red meat and total animal fat are associated with increased risk for prostate cancer. Even though vitamin A is suggested to prevent prostate cancer, there is no sufficient information to support it. A recent study in Finland, in which men were taking low doses of vitamin E, 40 milligrams, found that men taking the vitamin E had less prostate cancer than men who are not taking the supplements. Since this was the first study to show that vitamin E may protect against prostate cancer, and the results were considered only suggestive and not definitive, new studies are being done to see if vitamin E can protect against prostate cancer. Until more studies have documented to find out which, if any, specific vitamins can protect against prostate cancer, the best prevention is to eat a diet high in fruits and vegetables. These should include a variety of leafy green vegetables, yellow vegetables, and various kinds of fruit. The National Cancer Institute recommends eating 5 servings of fruits and vegetables each day. This is the best way to eat a variety of vitamins and nutrients that may help to lower the risk of developing prostate cancer. Total fat intake should be reduced to less than 30% of total calorie intake. Chemoprevention. Because of its slow-growing nature, prostate cancer is an excellent disease for chemoprevention. Chemoprevention is a new method where a drug is given to reduce the incidence of prostate cancer in men who are at high risk. The following groups of men are considered high risk for developing prostate cancer: immediate relatives of men with prostate cancer, men with a diagnosis of aggressive form of prostatic intraepithelial neoplasia, PIN, men with early low-grade prostate cancer, probably African American men. A number of agents are currently under research trials. Finasteride, Proscar, is a drug that is being used for benign prostatic hyperplasia, BPH. It inhibits the enzyme reductase, which is necessary for conversion of testosterone to stronger male hormone, dihydrotestosterone. A research trial using finasteride is underway, and the results should be available in 10 years. Retinoids, which are vitamin A derivatives, are another class of agents which show promise in preventing prostate cancer. It is shown to inhibit prostate cancers in rats. Small research trials using the retinoids as agents to prevent prostate cancer are underway to examine its efficacy. Psychosocial impact. Emotional distress. Impairment of sexual dysfunction. Changes in social roles. Emotional distress. Prostate cancer and its treatment produce a range of uncomfortable emotions, including fear, anxiety, frustration, anger, sadness, and depression. Patients may be frustrated because of the change in their lifestyle due to prostate cancer. Fear of pain and death from prostate cancer can become the main concern. Aside from experiencing physical side effects from the treatments, men have to cope with an assault on their sense of masculinity. Embarrassment from complications such as urinary incontinence makes social involvements difficult. Frustration also occurs because of different treatment options that a man must consider and choose his treatment from. These emotional distresses are often accompanied by trouble sleeping, difficulty concentrating, and a feeling of fatigue and tiredness. These emotions are usually most intense several months after the initial diagnosis. With passage of time, the emotional disturbances slow down. A man should understand that some anxiety and depression are normal when a serious illness such as prostate cancer occurs. To ease the emotional distress, it is important for men to maintain as many of their usual activities as possible to keep the mind away from the disease. Men should also discuss their fears and concerns openly with their families and their doctors and be willing to accept their support. They should share their feelings with other men either one-on-one or in a support group. It is important that the families do not place an extra burden on the patient emotionally by telling him that a positive outlook will make him healthy and that a negative attitude will worsen the disease. Short-term use of sleeping or anti-anxiety medications is often helpful. If the emotional distress is severe or persists for many months, a consultation with a mental health professional may be needed. Impairment of sexual function. When men are diagnosed with cancer of the prostate, they develop fear that the cancer and the treatments will impair their capacity to enjoy sexual activity and to satisfy their sexual partner. Men are more likely to be distressed about the sexual dysfunction if they are young, less than 50 years old, if they are single, if they are in a new marriage or serious relationship. Surgery and radiation treatments can interfere with the erectile function, while hormonal treatment can decrease the sexual desire. Quality of life refers to a man's overall well-being, including physical and psychosocial aspects of his life. In one large study, some men even gave up prolongation of life over loss of quality of life. Some men experience sexual difficulty even after a surgical procedure that does not physically impair sexual functioning, such as transurethral resection of the prostate, TURP. They reacted to this change in their physical response with inhibited sexual desire. Sexual impairment can affect both partners. Men stay away from sexual activity with their partner because they feel guilty for arousing their partner when they cannot satisfy them sexually. Women often do not want to initiate sexual activity because they do not want to embarrass their partner. Another obstacle to sexual relations is the unspoken fear of contamination. There is an unspoken fear of transmitting cancer during sexual activity, and for men who received radiation treatments, the fear of exposing the partner to radiation. It is important to understand what normal sex is. Normal for a couple is whatever gives them the pleasure together. Sexuality is just one aspect of the need for closeness, caring, and pleasure. When sexual activity is impractical, physical expression of affection remains an important way of sharing intimacy. Therefore, the first step is to gather as much information as possible on the effects of prostate cancer and its treatment on sexual function. Understand that no matter what kind of cancer treatment is given, the ability to feel pleasure from touching is intact. Men who cannot have erections or produce semen usually still have the feeling of orgasm with appropriate touching. Learn new ways to give and receive sexual pleasure. Couples can help each other reach orgasm through mutual caressing and stimulation. Try different ways, including self-stimulation. Couples should strive to communicate openly with their partner. If a role reversal is required, express it openly. Men should talk about their feelings to their doctor, who may be able to guide or help find the right solutions. If needed, counseling may be helpful. Changes in social roles. Prostate cancer diagnosis and treatment interferes with many social roles. The disease affects not just the man, but his family as well. The role in the family as a spouse, father, or a grandfather changes. It ultimately threatens the unit because he may die early. If the man used to be the person who provided vitality, leadership, and security, his impairment will bring about changes in the relationship. Among other adjustments, his partner probably will have to take over some of his roles. These role changes can lead to both partners becoming resentful and anxious. The impact on social roles depends upon several factors. It depends on the physical and psychological impact of prostate cancer and its treatment. A second factor is how many roles the man was filling before his diagnosis. A third factor is the amount of social support that he has. Men who can ask for help and expect to receive it from a partner or spouse, children or grandchildren, an employer and friends are better able to deal with role change effectively. It is important to try to maintain as many social roles as possible. At the same time, it must be recognized that prostate cancer and its treatment will cause some disruption in social function. It is unavoidable. To limit the disruption, priorities must be set. Complications of treatment. The two major complications that patients and physicians worry about with treatments of prostate cancer are incontinence and impotence. Incontinence means the involuntary loss of urine. Impotence means the loss of sexual desire and erections. Impotence. Incontinence. General complications of surgery. Impotence. Male sexual function is actually divided into 4 components: erection, emission of semen, ejaculation of semen, orgasm. Radical prostatectomy removes both the seminal vesicles and the prostate gland. The tubes from the testicles, vas deferens, are also tied off. There will be no more fluid for semen. Therefore, emission and ejaculation will be absent following radical prostatectomy. However, orgasm, the sexual pleasure climax, is saved. Erections may be lost, partially lost, or nearly completely saved. The return of erections following surgery usually requires 3 to 9 months. After 1 year, it is very unlikely there will be any improvement. Erections are controlled by 2 tiny nerves that are stuck on the backside of the prostate gland. If possible, the surgeon tries to save these nerves. But if the cancer involves the tiny nerves, the surgeon cannot cut too close or he risks leaving cancer. Dr. Patrick Walsh popularized the operation that saves these nerves, and it is now called the nerve-sparing radical prostatectomy. Results with saving erections vary greatly. Patients whose erections are most often saved have the following characteristics: younger, below age 60, good, strong erections before surgery, no other diseases or medications, stage A or B prostate cancer. Patients whose erections are rarely saved have the following characteristics: age 65 or older, diabetes, heart disease, atherosclerosis or high blood pressure, weak erections before surgery, stage C prostate cancer. Urologists have many treatments for men with sexual dysfunction. The most common successful treatments are medications. Medications are only occasionally helpful in improving a man's libido. They rarely restore total potency to normal. Male hormones, such as testosterone, must never be used in patients with prostate cancer. Yohimbine is a medication that is commonly tried. Vacuum erection devices, VEDs. With a VED, the penis is placed in a vacuum cylinder and passively filled with blood. A rubber band is placed around the base of the penis like a tourniquet to maintain the erection. These devices are clumsy, but often effective. Patient-administered penile injection therapy. Patients can give themselves injections of medications which cause increased blood flow to the penis. The injections are given in the side of the penis. Each injection gives 1 erection. This is an increasingly popular option. Penile prosthesis. A penile prosthesis is a plastic cylinder, either rigid or inflatable, that is placed surgically within the penis. The prosthesis produces an excellent result, but does require surgery. Incontinence. Following a radical prostatectomy, most men will experience some temporary incontinence. The resistance to a loss of urine is less after surgery because the blocking prostate gland no longer is present. This leakage of urine occurs whenever the man's abdominal pressure is raised. When the man is upright, the increased pressure causes mild leakage. Most men regain good control of their incontinence. In fact, control of wetting is usually the single item that determines when a man will return to work following a prostatectomy. Some men are left permanently with a mild stress incontinence. This means that when they cough, strain, or get up quickly from a chair, they may lose a small amount of urine. Some of these men get a single pad in the pants to protect them from embarrassment. A few rare men, about 1 to 2%, are left with total incontinence. These men constantly require pads or devices to keep themselves dry. The patient with disease affecting the nervous system is more likely to suffer incontinence. Such diseases include diabetes, strokes, and other disorders of the nervous system. There are many causes for incontinence, and in fact, these are treatable. If the incontinence can be corrected by surgical repair, this is the treatment of choice. Other methods of controlling the incontinence are often useful, though not entirely satisfactory for every patient. Methods for managing incontinence include pads or diapers. Pads or diapers are the simplest method for controlling urinary incontinence. However, the need for daily changes in the bulk can be inconvenient. Cunningham clamp. Cunningham clamp is a padded clamp that is placed on the penis and clamped shut in order to prevent incontinence. It can be used for 4 to 6 hours at a time. The major risk of the clamp is damage to the skin. Condom catheters. Condom catheters, also called Texas catheters, consist of a sheath which fits into the penis. A small tube at the tip of the penis carries away any urine. It is inconvenient, and sometimes it is difficult to keep the catheter on. Collagen injections. Collagen is a protein collected from cows. It is used as a bulk filler when injected into humans. The collagen is injected in an effort to make the urinary opening smaller. This might help with urinary control. The injection procedure for the collagen is painless and requires no anesthesia. The collagen is expensive, and the success rate in improving incontinence is good only in those men with minor stress incontinence. The major risk of collagen injection is an allergic reaction. Artificial urinary sphincter. Artificial urinary sphincter is a silicone plastic device which is implanted to control urinary incontinence. There are 3 components: a fluid-filled cuff, a pump, and a reservoir. The cuff goes around the urethra and squeezes it shut. A pump is placed next to the testicle in the scrotum. When the patient pushes the pump, the fluid goes out of the cuff and into the reservoir, which is located in the abdomen. The patient then urinates during that time. The cuff refills automatically. The sphincter is placed surgically under anesthesia, which lasts for 2 hours, and the patient needs to stay in the hospital for 3 to 4 days. Complications that can occur with the artificial sphincter are breakage of the prosthesis and erosion of the prosthesis into the urethra. Medications. Medications that help with incontinence either relax the bladder or increase sphincter tone. The most common medication is oxybutynin, ditropan. Ephedrine is another medication that can be used to increase the sphincter tone. However, it causes elevation of blood pressure and is rarely used. Death. Death during surgery is extremely rare, less than 1 in 10,000. However, injuries occurring during surgery can lead to death within the first 30 days after surgery. Despite the rarity of death with surgery, a wise patient still has his will, living will, and power of attorney in order prior to surgery. Thrombophlebitis. Thrombophlebitis is the formation of blood clots in the veins of the pelvis and legs following a surgical procedure. It can occur in any patient who is put to bed rest following any surgical procedure, but is more common in prostatectomy patients. The chances can be lessened significantly by performing preventative measures such as wearing compression stockings during and after surgery, early and aggressive walking after surgery, and avoiding bending or crossing the legs. Pulmonary embolus. This is a blood clot traveling to the lung and lodging there. A pulmonary embolus normally happens suddenly and causes chest pain and shortness of breath. It can be fatal. Treatment is with anticoagulation or thinning of the blood with medications. Heart attack. During or following surgery, part of the heart muscle may not receive enough oxygen and blood supply. This causes a heart attack or myocardial infarction. Patients may or may not have chest pain. Heart attack may cause death. Wound dehiscence. Any surgical wound may come apart if severe stress is put upon the wound before full healing takes place. Wound dehiscence is unusual following prostatectomy, but does occur following heavy coughing or abdominal straining. The wound separation may need to be repaired in the operating room. Wound infection. Any surgical wound may become infected. Surgeons operate in a sterile operating field, use prophylactic antibiotics, and remove any dead tissue in an attempt to prevent wound infections. Obese and diabetic patients are the most likely patients to develop wound infections. If an infection occurs, the wound needs to be opened and drained. Hernia. A bulge pushing the abdominal contents through a weakness and a surgical scar is called an incisional hernia. These are uncommon following prostatectomy, but do rarely occur in patients with coughing, straining, or obesity. Pneumonia. Following anesthesia and bed rest, a patient may develop pneumonia from not breathing deeply and inflating the lungs completely. The pain of an abdominal incision makes normal coughing and deep breathing difficult. Patients need to cough and deep breathe extensively following surgery to prevent pneumonia. Cigarette smokers, past and present, are at greater risk. Lymphocele. Following the removal of lymph nodes that occur during a radical prostatectomy, the lymph from the legs and pelvis may accumulate in a pocket called a lymphocele. The collection itself is not harmful, but the lymphocele may cause problems by pressing on other organs. It may compress veins, resulting in thrombophlebitis and an inflammation of the veins. A lymphocele may also get infected and need to be drained. After surgery, a drain is left in the pelvis for a few days to try to prevent the formation of a lymphocele. Urine leak. After the prostate is removed, the bladder is sewn down to the urethra, and the catheter is left going through this sewn junction. If the catheter is removed too quickly, the leakage of urine may occur where the stitched closure has not had enough time to heal. Urine leaks are not usually serious. The catheter is just kept in longer. Blood transfusion. Blood loss may occur during and following any surgical procedure. Small amounts of blood loss is unimportant and does not need to be replaced. Blood loss of 3 units or more usually, but not always, requires transfusion of blood. Blood loss from a radical prostatectomy averages about 3 pints. Blood loss from cryosurgery, brachytherapy, lymph node dissection, or orchiectomy averages less than 1 pint and does not need replacement. Stroke. During or after a surgical procedure, if the brain receives too little oxygen or blood, a stroke or cerebrovascular accident (CVA) occurs. This damages part of the brain and may leave the patient quite disabled. The anesthesiologist is present in the operating room to make sure enough oxygen is being given. Benign prostatic hyperplasia, BP.